All right, good afternoon, everyone. Thank you for being here. I'm going to call to order the Green Mountain Care Board's hearing of June 7th, 2023. My name's Owen Foster. I'm the chair of the board, and with me today are two other board members. We'll go through and do introductions later, but first I want to thank everyone for having us and our esteemed panel for being here. The real point of being here today is to hear from everyone that's on the panel and learn about how they're solving some of the healthcare problems and challenges we're facing here in Vermont. There's a number of creative solutions that they're doing, and hopefully there'll be things that we can all learn and take home. I want to thank Kristen Lajeunesse and Julia Bowles for all the work that they did coordinating this entire event. They worked tirelessly to make this seamless and smooth. I also want to thank Dave Merman, who's a board member. This was supposed to be his panel, except he's currently accessing our healthcare system, and so he is not here. Member Tom Walsh is also unable to attend today because of some medical issues, and we also have Julia Bowles and Mike Barber, who are also under the weather and unable to be here. So we are not helping keeping our costs of care down. But hopefully they'll all be mended soon and back. I want to provide a little bit of an overview of why we're here and what we're doing. First, the healthcare system in Vermont is under extreme strain. That strain extends from our academic medical center to our community hospitals, to our critical access hospitals, to our non-hospitals, to our mental health, to our long-term care, to everybody providing medical care in their communities. And they're all important. Each and every component of our healthcare system is critical, and we need it sustainable and sound. At the same time, we're having problems with the costs of care. Businesses and families are struggling under the financial component and investment that it takes. And so we're trying to find ways that we can improve care in affordable ways for Vermonters. What we're seeing in individuals is we're seeing increased underinsured rates and delay in care. And that then translates to our hospitals taking in patients that are sicker and more costly for them to care for. Hello? Hello?
Sorry.
Oh.
Hold it closer to your mouth.
How's that? All right. For those of you that know Dave Merman, he has a booming voice, and he could do without the mic. So I want to go around briefly to our panelists and have them all introduce themselves and explain where they come from, and then I'll give a little overview of the care board itself, and I'll have the care board members introduce themselves. So Dr. Marvin, would you like to start?
My name's Katie Marvin. I'm a family physician at Memorial Health Partners. How much detail do you want?
Keep going.
I went to medical school in Baltimore. I saw some different strains in different ways than we see here. I did my residency in Vermont and a quick fellowship, and I've been here ever since. And I've been at Memorial Health Partners for 14 years and have my family here and enjoy caring for our community, knowing people in many different ways. It's like 1 degree of separation from everybody. Seems like my husband's lived here his whole life, and I knew more people within 3 months than he did.
Thank you, Katie. Good afternoon, Stuart May, CEO of Lamoille Health Partners. Joined this community 3 years ago.
Good afternoon. I'm Melissa Volansky. I'm also a family physician at Lamoille Health Partners. I've been practicing there for about 24 years. I graduated Stowe High School and I came back to the area in 1996. I've been a buprenorphine provider there for almost 20 years. I don't really know how long anymore, actually. And I've been in about the last 6 years the chief medical officer role, so I'm also responsible for recruiting the workforce, trying to make our work environment sustainable, trying to practice transform so we can improve quality and reduce costs and make sure that we have excellent care for our entire community.
Hello, my name is Barbara Rosenthal. I'm a family physician and I'm board certified in addiction medicine. Came to Vermont and then to Massachusetts, back to Vermont from serving in Wisconsin in the National Rural Health Association. I've served on the Vermont Medical Society, the Massachusetts Medical Society, and the Public Health Committee of the American Academy of Family Physicians. We are part of a high-capacity substance use disorder practice, and I'm excited to be with you today.
I'm Caroline Butler. I'm a nurse practitioner and one of the founding members of the Johnson Health Center. My background is all over the place with different organizations, but most recently I have worked as an embedded provider in a syringe services program. I've worked in FQHCs and am now working in our own practice, which has been great.
Hi, I'm Erica Scott, Assistant Executive Director at Lamoille Home Health. I became familiar with the organization when I was asked to be on their board of directors many years ago. And then after a few years, I became their youngest chair. At the time, I worked for my father's construction company in Middlesex for over 10 years, and then took a position in finance with Lamoille Home Health. Bit of a jump, but my interest in politics, but specifically the political side of healthcare, kind of created an opening for me to dive more into that general role at the agency. So I've been pretty fortunate to work under and beside Kathy, who, as she'll probably mention, has over 30 years in this industry. So I couldn't have asked for a better mentor, and I'm excited to be here.
Hi, I'm Kathy DeMars. I have been at Lamoille Home Health for 30 years next week. So, thank you. I'm a registered nurse by trade. I started in the field at Home Health, then I became the director of the long-term care program, then I became the assistant executive director to the executive director, which I took over in 2010. So for the last 14 years, I've been the director of the agency. I've lived in the community over 50 years. I've raised my children here. My children are raising their children here. So we're very deeply rooted into this community. Thanks.
We can go over to Michael, and then we'll.
Thank you. Michael Hartman. I'm the Chief Executive Officer at Lamoille County Mental Health. Been with Lamoille for about 10 years. Have been doing this work since I walked into a group home 40 years ago to take a part-time job working with folks coming out of Vermont State Hospital and coming into the community and just don't know when to quit. I pretty much have done most roles that happen within our agency, which serves both mental health needs and intellectual disabilities as well.
Hi, I'm Don Dupuis. I'm a general surgeon and the chief medical officer at Copley. I was an engineer before I became a surgeon, so that kind of gives me a weird combination of outlooks on life. I went to medical school and graduate school at UVM. My children are Vermonters. Along with Dr. Marvin, we serve on the board of the Vermont Medical Society, so we get to deal with these ideas from a slightly different perspective from time to time. And basically my job at Copley, when I'm not being a general surgeon and providing care directly, is to ensure that the organization provides exceptional care close to home.
Joe Wooden moved up here in 1983. I used to be a flatlander. I guess I still am. Took a job as a systems engineer for Belden Wire and Cable. My background's also engineering, but I'm a systems engineer, so the real engineers think I'm not really an engineer, but worked in healthcare at MCHV as a management engineer. That happens to be now called UVM. Went to CVH Gifford, stayed there for 17 years, and then I became a prodigal son and left because my wife died of cancer. I always appreciate my healthcare experiences personally. I think we all do, because it helps inform us about the work that we do. So that was tragic for me, and I went to Martha's Vineyard, then I was banished to Alaska, and Copley accepted me back. I was very thankful, and so here I am as the administrator. Thank you.
Amy Tatro. I am with Jenna's Promise, and my day job is accounting and administrative work at a construction company. So that's a little bit different than normal stuff, I guess. And then my experience comes in everyday living and lived experience with somebody in substance use disorder and how that has affected our family and the work that we've done after my sister-in-law's death to try to help wherever we can to help people in recovery.
My name is Dawn Tatro. I'm the founder of Jenna's Promise. We started Jenna's Promise about 4 years ago, but our journey started many years ago with Jenna struggling from addiction. And when we lost her to an overdose, we decided that we could lay down and die, or we could get up and make a difference and help with the gaps in the system. And that's what we've been doing.
My name is Meredith Loomis. I'm from the Manor. I've been there for about 11 years with a brief hiatus in between that. Started as a floor nurse and worked my way up and took on the role of director of nursing about 2 weeks before COVID. So it's been a journey.
Hi, my name's Lynn Smith. I'm the executive director for the Manor. I'm a woodchuck. Sorry, Joe. My family is Waterbury Center. But anyway, I've been at the Manor 18 years as the administrator, my first administrator job. But I've worked in healthcare, long-term care for 40 years plus. And I love every day that I'm there. We love our residents, families, most of the time, and just enjoy being in the community and doing the right thing for the right reasons. Thank you.
Hi, I'm Russ McCracken, staff attorney with the board. Do I need to say more? Thank you. I've been here about 2 years and was in private practice before that.
I'm Susan Barrett, and I am going to remind the panelists to speak very loudly into their microphone and make sure that folks, like my friend Sandra Heath here in the front row and everybody in the back row, can hear us. So I have been at the board for 10 years. And before I was at the Green Mountain Care Board, I was the Director of Public Policy for an organization called Bi-State Primary Care. And I see Mary Kate Molman out there who is in that role right now. And they represent the federally qualified health centers in the state of Vermont. And before that, I actually was working in private industry on actually for a vaccine company. So I'm delighted to be here, and I can't wait to hear the panel discussion today.
Hi, everyone. I'm Robin Lunge. I've been on the board for 6.5 years now. Prior to that, I worked in the Shumlin administration on healthcare reform, and prior to that, I worked for the Vermont legislature for almost 10 years as nonpartisan staff. I grew up in Brattleboro, and I'm excited to be here and to learn more about the community and kind of get an update. It's been a little while since I've been up here, so thank you. Oh, yes. Okay. So I'm also supposed to do a brief reflection from my tour. So I went to the Manor and got a tour from Lynn and Meredith. And I would say I was very impressed by how they have really infused caring and a focus on their residents in everything from the decor, the layout, renovations, focus on activities or life enrichment. I learned a new term today. And so that was really amazing and wonderful to see, and also to learn a little bit more about the challenges that they had both through COVID and post-COVID.
Great. Well, my name is Jessica Holmes, and I've been on the board for about 8.5 years. So it's my second tour of duty, as I sometimes say. But I'm really happy to be here. We did a lot more traveling board meetings before COVID, and we've missed that opportunity. And this is our second one since COVID has subsided. I don't think we can say it's ended, but it's subsided. And it's always wonderful to come out and meet people in their communities and to frankly see all the hard work that everybody is doing to care for their communities. So I really appreciate this opportunity to be back here. So I did a tour of the emergency room and the hospital, Copley Hospital this morning, and met some incredible caring and compassionate staff, which was always wonderful to see. It's clear how resourceful the staff is, working with tight budgets to deliver really high quality care to this community. I did hear about some of the likely capital investments in the future, which I'm really looking forward to probably seeing CONs about. But anyway, it was a wonderful tour, and I'm really, really grateful for this opportunity.
And I'm Owen. I've been on the board for, I think, 8 months. I started in October. Dr. Merman and I started at the same time. It's a huge honor to have this position. It's a huge responsibility. And one of the things I'm focused on is trying to get out in the communities. So this week I was actually here at Copley and with their board on Monday, hearing a lot of their thoughts and concerns and questions and what they're doing that's working well. Yesterday, I was at Blue Cross Blue Shield, and then today, this morning, I had a chance to go to Lamoille Health Partners, which was great. My first case ever in my life in Vermont as a lawyer, which was my old job, I partnered with Lamoille on some issues, and it was really an amazing collaboration and extremely helpful. So I know their spirit, and I know how they work, and I know their people, and it was really great to get back there and see what they're doing. Some of the takeaways I had, at the Care Board, we sit and we really look primarily at hospitals, ACOs, and some insurance rates. We don't have regulatory authority over independent practices or mental health or long-term care, but those are such critical components of the system. And so hearing and learning about how an FQHC is working and what they're doing helps inform our regulatory decision making. And today I learned a little bit about the whole person care they provide. I didn't know really anything about dental care, but I learned about some of the friction that keeps people from accessing care. And in dental care, some of it might be shame and embarrassment of the problems that they have. It might be financial, in that dental insurance is not as robust as I think we would all like. And third, it's just painful. And so people delay care in the dental and oral health space, and that really leads to extremely sick people. And it doesn't feel good for people. So I learned about that. I learned about some of their work with urgent care and transitioning and connecting that with mental health and how they do screening to make sure that people are getting the mental health care that they need. And it really opens your mind to how everything's actually working on the ground. So the Care Board has been focused on this. We're continuing to be focused on it, and that is informing ourselves of the entire system and what everyone's experiencing. And so I want to thank everyone for having us today. We learn from you, and hopefully we make better decisions because of that. So I want to thank everyone for that. A brief little overview of what the Care Board does and our role in healthcare. Like I said before, our primary responsibilities are regulating hospital budgets and also the ACO, or now ACOs, and then also insurance rates. And we do see financial strain at the hospitals. We do see financial strain and the insurance rates that folks are paying. I have a lot of meetings with a lot of different types, and there's one consistent message, which is everyone needs money. And they're all right. The insurance companies have low reserves. There's concerns about solvency. The hospitals have had declining days cash on hand and operating margins for the last 5 years. It's a line downward. And then also everyone else who's providing care is struggling financially. And so we sort of sit in the middle of this and try and make informed decisions that are best interests of all of Vermont and all of the providers and all the patients. So we are getting out in the community. We're trying to learn from you. We're trying to bring out the voices that are doing great work so that those experiences can be leveraged and utilized by others, because I think sometimes people are doing the work, but not everyone else knows about these strategies that people have. And I've already learned 4 or 5 things just this morning that I had no idea about. And so we're hopeful to bring those out so people can really be integrative and work together to solve some of our challenges, because the financial challenges are real. And so we need to kind of think about how we can solve them together. So we have 2 primary panels today, and the first is going to be focused on creative solutions to improving healthcare access. We have had challenges to access to healthcare in Vermont for a number of years. We have some fairly long wait times to see specialists at hospitals. We have delays in getting to primary care. We have access issues with dental care, all of it. And so we want to talk about some solutions that folks are working on to work together and solve some of those problems. And so our panelists today on this topic are from Jenna's Promise, Copley, Johnson Health Center, and Lamoille Health Partners. And so I'll turn it over to you all to share your thoughts. Oh, sorry, and Lamoille Mental Health.
Thank you, and thank you for having us. We're really excited to be a part of this conversation. Something that Jenna's Promise has chosen to focus on pretty much immediately as soon as Jenna passed away was safe housing. That was the number one thing, and that became one of our biggest pillars. From there, we developed workforce development, health and wellness program, which is yoga and meditation and different versions of health and wellness outside of your typical doctor's office, and then stigma reduction and community connection. So those are the 4 pillars of Jenna's Promise that we've really worked hard to create a whole body care system to help people who are in recovery. This has allowed us, our population that we deal with are people usually straight from prison, people straight from treatment centers, as well as people who have been trafficked. So these are people who are coming to us with absolutely nothing. They have showed up at our doors with clothes on their backs that probably aren't even appropriate for the time of weather that we're in the season. And we are no barrier. So we are getting them their clothes, we are getting them identification, we are getting them skills. We're doing all of it from the very beginning through and trying to help create a recovery system that just wraps them up in care and whole body everything. And that is kind of what we've focused on. And I'll pass this over to Dawn now.
Thanks, Amy. I think one of the things that we, like Amy said, we are no barrier, and it doesn't matter who you are when you walk in the door. We meet you where you're at, and whether you have not had an ID for 3 years or a tax return, but we build you back. And one of the best things I think about our program is it is trauma enforced. And when I had a talk with one of the residents this morning, she said, I have been to 6 IOPs. This is the only IOP that has ever helped me. But it's trauma-based. And if you can work on that person and give them the skills so when they are back out, they can deal with life and they don't feel like they have to use. And then developing them in the workforce. And right now we have 2 girls that are graduating for a year. We've had a few, but these 2 are special. They both came from prison, and both of them have full-time jobs. Both of them are going to college, and it just shows that they're being protected part of the society now.
Hi. First, I'd like to thank the Green Mountain Care Board for inviting us to participate. At Johnson Health Center, we're part of a nonprofit, A3B Acceptance, Believing, Bonding, and Belonging. We basically practice a comprehensive approach to substance use disorder by specialists with wellness-based care. When we first moved into our new space about 20 months ago, the space was generously provided by the Tatros. We had 36 patients, and in 20 months, we've now grown to about 285 patients, 108 of which carry a substance use disorder diagnosis. Our first priority is access. We try to look at the low barrier approach to care as trying to remove all barriers that possible, low to no barriers. We treat people the way we'd like our family members treated, and that's what we try to hold in our thoughts as we treat people. How would we like our mother, our father, our brother, whoever treated? We work for near open access. We do intakes if we get a phone call or a drop-in pretty much 7 days a week. We try to accommodate and get patients started the next day the pharmacy opens pretty much, which has been pretty successful. We've done, 9 new people like that in the last several months. We look at it as an in-house RAM program, I guess. We have a lot of support from community partners. We work with Cora pretty closely. They provide a lot of supplies to our patients, phones for them to access telehealth. We work with Vermonters for Criminal Justice up in Burlington for off-site care. We do some off-site visits, particularly for wound care and other things like that, when patients can't come to us. We try to coordinate for a smooth transition from incarceration, and we really rely on the use of peer support staff to enhance our services. They've been helpful in just bonding with people, getting them places, and really provide a big backbone to the services. One of our successes with partnership is our almost here naloxone vending machine. We did the research to start that program and found that we couldn't house the grant because we were not a nonprofit yet. Jenna's Promise jumped in and housed the program for us, letting us be the first. Johnson will be the first site in Vermont with a naloxone vending machine. I think 300 doses. Yeah, 300 doses. We function as accepting people as they are and where they are. We believe that it's our philosophy to encourage patients to define their personal goals and with our support, but not with our control. And we really try to respect their agency and their definition of recovery. Our ultimate goal is to provide services to patients who have not been reached by traditional practices for whatever the barrier, to provide specialist level care for people and who require a level of service that's too complex or not feasible in a typical family practice for time constraints and other reasons. We work with our team and our community partners around the psychosocial determinants of health. Some challenges are just maintaining supports. People have been forced to leave the area because of the housing crisis. They may be coming out of prison, out of rehab, out of area, and all those other kind of reasons. And we're very excited to be hosting UVM medical students in their addiction medicine rotation. I think, was it this summer? Yeah. So we look forward to taking patients referred to us who might not be a good fit in a typical primary care setting. Our executive director, Jeffrey Butler, is our point person, and he can't join us today because we're participating in a dental initiative. We have 2 of our patients seeing a Vermont dentist, trying to get them started and see if we can pilot this program, which is very exciting. And I could guarantee if you reach out to him, he will find us. He found me in the woods in upstate New York last weekend that we had at a wood firing pottery event because we had a Medicaid crisis. So he's very good at that. So you can reach him and he will always be able to reach us. I just want to highlight a few initiatives of our program and then hand this to Caroline. We work with hepatitis C treatment. We do reproductive health, including LARCs, gender-affirming hormone therapy, PrEP, open access to STI screening. We are in the initial steps to be designated as a medical home with primary care. We do pain management, including acupuncture, trigger points, nerve blocks, and other non-opiate techniques. We do psych med management. We're partnering with Laraway Health Center School, and we do the dental initiative. And we are currently very excited to be working on xylazine and trying to be proactive. We see the xylazine and the meth really pouring into Burlington area, and we're trying to see how we can try to manage treatment, the withdrawal, the infections, the amputations, and other things that I think is going to be a community-wide project, and we're very excited to work with people on that.
Thanks. So, the piece that I really want to add in here is that through the last 2 years, we've really developed some incredible community connections. And that in all of the time that I've worked in addiction and recovery, this is the first time that I've seen an entire community come together and really wrap people fully. Those, talking about the vending machine, like that was a perfect example of a community project really that rose to meet the needs of the community. It was an initial idea after we lost a community member to an overdose. We reached out to Cora. We reached out to Jenna's Promise. Jenna's Promise took the baton and really ran with it. So it was a great example and a great illustration of community working together to make change. So that's a piece that I really think is important to bring forward and to focus on as we have these conversations.
Oh, hi. Discussion about Copley Hospital. I usually try to be very efficient, so everything's on my computer. When the computer doesn't work because of the local area network problem, I'm now bringing it up from memory. So I appreciated Caroline's comment about the community coming together. So it's an acute care hospital. We're one piece of the puzzle. I like to do puzzles, but if you only see one piece, it's like you really got to look at everybody around this table and the discussion about what we do with patients. So we deal with specialists and we deal with folks that need to be in the hospital. They either need surgery or laboratory work or diagnostic imaging, but we sit on sort of that acute care side, but we're all part of this constellation that works. And we accept referrals from everybody around the table and we send our patients back to everybody around the table. And that's the way it works. And if we can't take care of them, we send them up to UVM or Dartmouth or somewhere else, maybe in Boston. But so we sit there. We don't really do primary care, although we have OBGYN in a birthing center, but for the most part, we all have our little niches. So this is an interesting hospital that just stays as an acute care hospital, critical access hospital. So we're very happy to have the discussion. I think I sort of talked about this earlier. COVID has driven us together when we were desperate, looking for personal protective equipment or policies or how are we going to get through this. And we're still post-COVID, but it's great we're talking about how are we taking care of the patients in the community, because these are the patients we see. They're all sort of our patients. Now and then we do draw for outside, for the most part, orthopedic, same-day surgery, but we deal with the same book of business and people, so this is a great discussion. I'm going to pass it over to Don for a few comments. Dr. Dupuy.
Thanks. The topic is creative solutions that are improving healthcare access. I don't really know how creative the solutions are, but we definitely have solutions. So to talk about this, I could just see my wife eyes rolling as I sort of approach it from an engineering first principles point of view. So when I think about proving access, I think access to what? And then I think, well, it's episodes of care. That's really what we're providing. And that's sort of, I can get my head around that a little bit better. And so I think of episodes of care sort of in two ways. First of all is the number of episodes of care, because that certainly if you want to increase it, that would be good. But there's also the type of episodes of care. And that side probably is more amenable to innovation, and which is why I think it's so heartening to hear about the work that the Johnson Health Center and Jenna's Promise is doing. I think that's that is creative and an important innovation in the types of care our community are providing. The other innovation that when you think about type of episodes of care for any given community, particularly a rural community, is that we just don't have every type of care available to us. And then technological innovations can help there. And so sort of televisits and telecare is the obvious thing that you think about there. So at Copley, we do a fair amount of that with pulmonology and sleep medicine. We also tried nephrology and rheumatology, and for whatever reason, that really wasn't subscribed to quite so well, but those things are certainly possible. And if you think about it from an industry-wide point of view, neurology and ICU are both really the stars. They're widely adapted and they work tremendously well. So there's quite a bit on that side of it. Unfortunately, on the number of care episodes, that's just a tougher row to hoe, I think. Because you can either see people in less time to do more episodes of care, and that doesn't sound like a good answer, or you can have providers see people for longer periods of time, and of course that definitely has diminishing returns if you do that to the extreme, and that sort of leaves you with more people providing the care as the other solution. And we have definitely had access to care problems, which manifests itself in long wait times to see somebody in OBGYN, orthopedics, cardiology, and general surgery. And basically, we have more providers either on the way or in-house seeing more people now than we did before. So it doesn't feel very creative, but we're definitely expanding access to care.
As the federally qualified health center in the community, we have some additional resources from the government, and it is our mission to see everybody regardless of their ability to pay. So access is kind of our prime value. It's our most important character. So we have done our best to expand access, including, little things like Saturday hours, and we now have added an express care track to our regular working hours during the day because we were having a lot of trouble getting people in for acute things that were needed. So that's really helped patients get their needs met in a more timely way, and hopefully has decreased needing higher levels of care, or maybe using the emergency room for convenience rather than for emergencies. We've added primary care physical therapy to our practice. The idea of being patients are waiting a long time to get in for physical therapy. Physical therapists, I think, get frustrated that they don't get to see people until their problems have become so intractable because they've been going on for too long. So we have somebody in the office we can get people into, and hopefully with a short intervention done at the right time, maybe not need as long a course of physical therapy or avoid other more aggressive and expensive interventions. We have the dental clinic is under our umbrella, and we have them doing some outreach into the elementary school in Johnson, and we also have a van that is being developed to allow them to access more locations in the community so that patients can have easier access to dental care, and maybe even where they go to school or where they live. We have embedded mental health clinicians in the primary care practices so that we can intervene in a timely and early fashion for mental health concerns. And those folks see people also for brief interventions, and also connect them to longer term therapy and other higher levels of care if that's what they need. We have medically trained interpreters so we can take care of people with different languages, which, as I've been here almost 25 years, that group has been growing. We have a lot of workers working in our agriculture industry. We have a lot of new Americans who are coming from all over the place. So that's really wonderful to be able to understand what they need and also be able to explain our impression to them in a way they understand, and to not miss cultural cues because we have somebody who really is able to pick up on that. We have a sliding fee scale for people that don't have other resources, and that works at our pharmacy as well, since affording drugs is a really important problem, and a lot of patients don't take their medications for that reason and sometimes get sicker. And so we are really proud of that part of our program. We're very involved with the Blueprint for Health and the community health team, which does so many things, but among other things has patient advocates that help navigate coverage issues, help solve problems with medication costs, help take care of barriers like transportation, housing, has been engaged in getting people food through the Everyone Eats program. We have a Salvation Farms gleaning program. We have the Heart Healthy Meals on Wheels program. So they do a tremendous amount of contributing to the overall health of the community and preventing, hopefully, progression of advanced disease. We are offering some school-based care at Johnson Elementary. We have behavioral and dental clinicians there. And we just got a grant to embed 2 behavioral health clinicians in the Morrisville and in PA and PA middle level. So we're going to be able to provide some mental health services there as well.
Sure. One of the things that we've worked on, as you can tell, there are quite a few people in recovery here. So it is such a big, important topic in the state and nationally. So for the last several years, we've created similar low barrier to no barrier access to care for opiate use disorder and substance use disorder, which we call our RAM program, Rapid Access to Medication. So a patient could have seen me this morning as a walk-in. I would have done a visit with them, a connection to our MAT team, care coordination, medication, same day, no wait, no inpatient, So creating an opportunity that recognizes that many of our patients who are struggling with substance use disorder are working parents and can't go to an inpatient facility. So I would say that from my standpoint, most of our patients that are really struggling would do well with at least a trial of this approach. And so it's something that I've encouraged to all of the family medicine providers across the state at an annual visit. Now that there's no X barrier, it really should be expanded to everyone in OB and peds and internal medicine, and basically anybody could be doing this. So we've created opportunities for other agencies around the state to learn from our, trial and error, and basically copy protocol if necessary, so that we can share these systems that we find to work extremely well. And I'm glad that Melissa brought up the community health team and Blueprint, because really, I think the thing that we've recognized over the last several years is we have to use all of our partners within our building and outside of our building. And we need to allow people to work at the top of their license and really trust them, trust our peers. So with my MAT team, they do most of the work for me. I'm probably helpful, but but they are really doing a lion's share of it. And similarly, the fact that, as Melissa mentioned, she mentioned it quickly, but I want to emphasize, let's say I have a kid who's in a mental health crisis. The fact that we have expert clinicians in-house who can see that kid today is unbelievable. So when we read in the paper, these kids, or hear people saying, well, I can't get my kid in to see anyone for 6 months. I'm like, no, we need to see them today. And they probably don't need to be seen forever. They just need help right now. And then they need a couple visits. And those that need longer term care will be triaged by that clinician and will be set up with a longer term clinician. But the fact that we can get people in really quickly, it's sort of the same model as MAT, RAM, sort of everything in my mind is turning into like an expert kind of model, where it's let's have some opportunities for people to have some triaging real quick, get the care quickly, and then decide who really needs that long-term care and who really needs to wait. I'm going to mention two more things. One is, several years ago, I think it's a creative solution, which was when we created an upstream Lamoille group, which many people here are part of, which was basically just to decrease silos and reduce redundancy between organizations in the community. And I think that the Lamoille Health Partnership does a similar thing, probably in more formal ways, creating systems where we all know what each other are doing, and basically like any door is the right door kind of approach. Like if somebody presents to a WIC office visit, they would be able to know who they could call for help for that person. Or if somebody presents to Dawn, she knows how to reach me or anybody else. So just creating systems where community members who are all involved can contact one another. And then I think like working at the top of their license would also apply to the triaging systems between primary care and specialists. And I guess we can comment on that later. But there's some real potential for cost savings if we were to use specialists for specialty care as opposed to primary care.
Thank you, Katie. I'm just going to close addressing workforce and a couple of things that we are doing to address that. One, within our oral health service line, taking on the grow your own type of philosophy. And there we're actually training individuals to come in, start out as a sterilization tech, move to that dental assistant role, hopefully start to feel that this is a field that they want to remain in, and then we look to support them through getting into school to become a registered dental hygienist. Lastly, as it relates to primary care and family medicine, recently we worked on a federal grant that we were awarded to bring a new primary care residency program to the state, one that is very much outside the box. And what you've started to hear from our colleagues at the beginning of this panel is the work that we do collaboratively. So that model that we'll be working on the next 2 years will be to develop a family residency program with our hospital partners to really train the next set of physicians in rural health, where we're going to look to, through that educational process, how you start to marry medical care or needs and social cares, along with those telemedicine tools for deployment that many of us did not become well versed in until the pandemic hit. So that's what we're starting to do. That's a little bit longer path, but as I've said in a couple of different forums, we can no longer sit back as it relates to workforce, and we have to find innovative ways of doing that. Thank you.
Well, I think I'd want to emphasize that really there are a variety of providers who do mental health care. As you've heard, Lamoille Health Partners. There's a substantial private community of providers in our area. And so what Lamoille County Mental Health does on its mental health side is often to be working with folks who are probably tend to be more severely impacted by their symptoms. We have about 15 to 20% of the people that we serve live in a 24-hour care environment. We either have them living in a situation where there's a paid provider with them overnight, every night, or we have folks living in a care group living facility. And then we have 2 facilities that are crisis-oriented, where folks, we have 3 beds total in those 2 sites. So there and in our emergency crisis program, mobile crisis program, those are 24/7 programs that we operate. So we are responding round the clock to a variety of things, some of which are referrals out of the other folks in the system who've spoken here, and some also arriving via police, schools, other parts of the community. I wanted to touch base about 2 or 3 of those efforts and where they've gone. But I don't want to forget to mention, and Joe made a brief reference to it, is COVID and the response that we were all able to put together was pretty amazing from my perspective. I took my position of CEO. I was already working at the agency, and 6 weeks later was the COVID emergency. And aside from really good timing, I think that the piece that was overwhelming was that this was such a medically oriented crisis, but we have all of those people that we're doing 24/7 care for, and we have a fairly light medical team, I'd say. So it would, the work of working with LHP, with the hospital, with home health, the nursing home, all of those pieces proved to be lifesavers for us. And I think it was a really important piece of how well things can work here when we all need to pull together and do stuff. On our end, one of the recent things that we looked at was the number of children who were getting, I would say, marooned, but not in a negative way, because the hospital folks were providing as much care as they could. But as the inpatient need for children to go into a psychiatric care facility occurred at higher and higher rates, it became a longer and longer wait for them to be sitting in an emergency room, often by themselves, because these were often adolescents, sometimes with parents, often with folks in the hospital and with our emergency team folks. And working with the Department of Mental Health, we have established a few months ago a program we call the Emergency Psychiatric Intervention for Children, which was to bring children out of that environment and have them in our facility, our main office. We took some rooms there and turned them into rooms that we could have children in, and children here being 6 to 18, and be able to do care for them during the day, Monday through Friday, 8 to 6, to be able to allow parents to have some time away, because often in these situations, if they weren't at the emergency room, they would be home with their parents, and the parents would be 24/7 providing that care. So we inserted this piece in and quickly found that not only was it useful for the families, but also it just started to divert the kids from needing to go to inpatient, because during that wait, they actually could make improvements. So that was kind of an on-the-fly, quickly creative idea, working with the ED and with our other resources. Another piece that I think has been amazing here really is what's known as zero suicide, which is trying to design systems in such a way that any person who may be at near decision-making to end their lives could have an intervention because of doing outreach intervention. So about 7 years ago or so, we started doing this just inside Lamoille County Mental Health, but quickly found that some of the tools we had, a screening tool for assessing risk for suicide, was also available at the hospital in their EMR, and also available at Lamoille Health Partners in their EMR. And so we were quickly able to get all of the primary care providers and the mental health providers to start using the same tool, which allowed us to, we haven't quite figured out a way to pull all that data together for everybody to be able to use, but independently, we now know we are all using the same tool to identify somebody who may be at risk and then construct interventions. And those started off with us doing most of the immediate care for somebody who was at immediate high risk. But as we've gone through the last few years, the behavioral health folks at LHP, the emergency room, other parts of our systems have learned how to do these pieces. And while unfortunately I can't say, and so we have zero suicide yet, because that's the goal of the program, but we had about 3 or 4 years of decreased suicide incidences in our area. And unfortunately, last year blew that right out of the water, and we had about 3 times the number that we might usually have had. But I think that we've established some really good ground in terms of how to bring this, which was a model that was really meant for a mental health clinic to use, into the whole community, and have every provider and medically, we've trained about 80 or 90 private providers in our area, and we have our team. So we have a really rich experience of people with the experience to know how to manage this issue right from the start, and really end up decreasing people going into inpatient psychiatry and other needs, and actually really shortening the time that they might be in that distress. The other piece that I wanted to mention that we were kind of in the middle of and struggling with due to staff hiring issues mostly is health equity, and trying to address, in related to the zero suicide piece, is that persons of color, LGBTQ plus, and other populations who are at high risk for suicide, higher than the average population. And so we're also trying to look from our perspective how to have more sensitive detection of people who may be at risk, and be able to do more interventions along those lines. I think we're also trying to look at access in terms of telehealth. We went in 2 weeks in 2020 from being primarily a face-to-face provider to being primarily a telehealth provider. And one of the things that has come out of that now is the recognition that this is a really powerful access tool. For some people, they want no part of it. They have no interest in doing screen time. For other people, it is a relief that they don't have to leave their house, that they can stay in their own living room, that they don't have to go into an office, and other pieces that create more anxiety for them. So I think we've hit some good spots on that, as well as we're working, we've submitted a grant to USDA, working with LHP to create a mobile outreach. We're trying to see if we can, if we get the grant, the idea will be to have a trailer that we can move around the county for people to be able to use telehealth by walking out their door or going to a local spot. And we're going to establish small studios around the county, both in our facilities and LHP facilities, so that people who prefer to do it that way, because they may still be traveling, but they won't travel as far, and go in and have a visit, therapy visit, psychiatry visit, case management visit, any kind of visit they need through a telehealth portal. So I think we're a pretty amazing, innovative area for, given the fact that we're about 4.5–5% of the population, we're doing some really tremendous pieces.
I had a couple of questions jumping off of what folks set up, but first for the folks dealing with substance use disorder, I wanted to understand a little bit about what you see as strategies that work best. And I ask because my old job, I worked for the Department of Justice, and we interacted with folks when they connected with the criminal justice system. And the folks were usually at their lowest of lows. They were sick, they were scared. And I think it was easy to observe that the criminal justice side wasn't really the answer. We also saw people in treatment that weren't able to stay clean. And from my casual observation, it seemed as though community really helped them the most. And I wanted to ask you guys, as experts in this field, what you observed as the most effective strategies for helping folks in that situation.
I think we look at the medication as a tool to enable people's brains to stop seeking substances, allow them to settle into to healing in other ways. And so the medication isn't the end goal, but it's a really important tool for people to use so they can get their housing, they can get job training, they can work to get visitation with their children, get their children back perhaps, become part of the community. So all those other pieces are essential to what we call recovery. And look at the distinction between recovery and being sober. Not using is one thing, but being in recovery is really moving forward with all those markers of recovery that I discussed, and really being able to re-enter the community as a member of the community. So I see that as a tool, and it can take a long, long time. Some people can come off the medication, and many can't, and that depends on their particular physiology, the length of time they've been using, how much they used, how much of it was fentanyl, how much of it was just oxycodone. There's so many different factors, and I think the limiting factor for so many people is stigma. And that really limits the access. And then you get into the other technical parts of access that we can deal with, but reducing stigma is such a big part of it.
One of the things that we found, we met with Johan Hari, who has done a lot of research in this, and he says that the opposite of addiction is connection. And I think that is one of the number one things that we found in our work. It is the reason the first building we opened was a community center, was so that people could come together and we could take down that stigma. And so the community would have buy-in too, because if you're offering yoga classes or educational classes for the community, then they're gonna come and enjoy those things while also not realizing that they're doing yoga right next to somebody who is maybe only 30 days in recovery. But then they realize that, hey, that person looks just like me. And that is not the picture. I can't tell you how many people have come up and said, that's not what I thought somebody who uses drugs looks like. And it's opens their eyes to say, no, these are real people who have real lives. They're our children, they're our friends, they're our parents, they're our brothers and our sisters. And when we treat them like that and we give them the opportunities and we say, hey, this was a disease, we're here to get you back. Somebody else also said to us that you wouldn't get mad at somebody who has a diabetic episode because they're sick. So why are we mad at the person who is sick with this disease when they're just trying to survive? And we really work on creating those stepping stones to getting the whole person back, to saying everything. You have lost so much in your experience, and we're going to bring it all back to you. And while we're doing it, we're going to tell you you are loved, you are human, and you are okay, and we've got you. And that has had a huge impact on the people we've helped. We've had our people in recovery stay in recovery longer. We've had higher success rates. If they do relapse, because relapse is very much a part of recovery, they're coming back to us sooner. They're coming back to us in a couple of days instead of a couple of weeks. And with the drugs on the street as they are now mixed with all sorts of different medicines, you can go out there and use just once and think that you're going to be okay, and then you die, because that's just not the way it is anymore. So the fact that they come back even within a day or two is life-saving for a lot of these people.
I've got one thing to add. I think that, just looking factually across the state, it's just providing a lot of options for people so that people have all different kinds of options for their recovery path and also different options in their communities. So we've known for some time that Lamoille County has quite a lot of options. There are counties across the state that don't have as many people in primary care who are comfortable prescribing buprenorphine. With the removal of the X waiver and the amount of availability of training or peer support, to some extent, I consider it inexcusable. But I would love to help. I mean, we've made that message pretty clear, but providing that availability to every county and every little town in the state, because primary care is should be available as a good entry point and a safe entry point. So I've had patients present for a RAM visit at well child checks, at a check for carpal tunnel, at all kinds of different things where it took 10 minutes or so for maybe that conversation to feel comfortable, and then it came out that that's what their real reason for coming in was. And so I think, having a lot of options, having it available everywhere, using really careful with your language, think about what words you're using so that it doesn't add to the stigma, and just be really nice. People feel terrible about themselves. They feel terrible physically. Like they really just need a lot of help. And sometimes you just need to kind of support them right away and then figure out the next steps at the next visit. You don't have to figure it all out that first day.
I would just add that stigma, I think, is the biggest barrier to this treatment, and it is what's killing people right now. So the words that we use, the way we think about this disease, when we talk about people with substance use disorder, and when we talk about treatment, medication is not assisting treatment. Medication is treatment. Just like Amy said, we don't ask diabetics to go off their insulin. There's just a lot of stigma in all of the things that you'll hear yourself or other people saying, and it really is deleterious to our patients. The rapid access to medication is super important, and many communities have solved this in different ways. Some communities have sort of started that in the emergency room. In our community, Dr. Marvin collaborated with everyone to make sure we have this kind of bucket brigade of providers who have appointments every day of the week to get people in within 24 hours to get treatment when they're ready so we can meet them where they are. I really applaud these guys for getting the Narcan machine. Narcan should be everywhere. Narcan should be in the schools. Narcan should be in all the practices. There's just no reason to be ashamed of Narcan, but my patients who walk into the pharmacy every week or every month and ask for buprenorphine, all the stigma that they have to deal with every day, I am so humbled by their experience. I don't know how it would feel if I walked into the pharmacy and asked for Narcan. Even though I know I can do that, just try it and see how it feels, and you'll get a little taste of what stigma is like. So I'm really grateful that we have so many good partners in our community, but I think those are the things that statewide would be really helpful.
I think just building off of what was just said, that sort of the idea of radical acceptance and always keeping the door open and helping people to take a step towards safer, and that doesn't always mean the same thing. People's journeys look very, very different. And that is one of the strategies that I think has worked well with many of the low barrier folks that I've worked with that are straight out of incarceration and really still in the thick of it oftentimes, is for them to know that the door's open. You can come back. There's no judgment. I'm going to help you with whatever's going on. And that is something that our community is also doing really well, is working to break down those barriers for people.
A couple of you mentioned workforce. It's an issue across the state, and I wanted to ask you guys a little bit about strategies you're using. Stuart touched on a couple, and that others have. And the first question is to Stuart. In your residency program, are there opportunities for others in Vermont to apply for those grants?
So this grant was through HRSA, through the Teaching Health Center, GME, which Congress enacted under the Obama administration. But the model that we put forward is a consortium type model. So from a educational standpoint, we had conversations before so I should back up. It took us a year and a half of work before putting the application in. So we've talked to our academic partners, both medical colleges out of the University of Vermont and Dartmouth, for faculty and didactic type of support. We have talked to, when we talk about a consortium model of incorporating to the best that we can all 11 FQHCs and 14 hospitals. It truly is a state program. While there'll be 6 primary sites, 3 in the southern part of the state, out of the Rutland area, Springfield area, and Randolph area. On the northern part, up by Northwest Medical Center and Notch. On the Northeast Kingdom side, northern counties, and NVRH, and right here in Morrisville, Copley Hospital, and ourselves. Those will be the 6 primaries, but we are looking to engage others in those selective or elective type of rotations. One thing that I've been quite surprised, and maybe it's because I'm not a clinician, is the amount of enthusiasm from our medical staff across the state that want to partake in education. So clearly, as we move forward over the next 24 months to submit the final application to ACGME, the accrediting body, I think everybody in the state will see that while there will be some primary players, I think our whole healthcare ecosystem will play an important role. And already some have come and said, how do we look to create other pieces? So potentially this could be another hub here in the state to support medical education in general.
I just got the mic, so I'm going to ask a question or two. The first thing I just want to say is I'm inspired by the deep empathy in this room among all the providers, just incredible empathy for the people that you serve. I wanted to just ask a little bit about, several of you mentioned COVID. How do you not mention COVID? We just lived through this incredible, unprecedented time. And I'm wondering if folks might be willing to share what COVID lessons, or it's such a disruptor, it forced so much innovation, it forced so much change. Some of it temporary, but some of it I'm imagining is more permanent. And I'm just wondering if folks might be willing to talk about what changes as a result of COVID in the way you deliver care, access to care. Some of it, I think we heard a little bit about telehealth probably staying, but I'm just wondering if there's other lessons learned or, integration, coordination among all of you that hopefully will stay as a result of what we all just experienced.
I'll just make a quick comment about nursing as opposed to providers and other issues, but nursing, many of the fields, we just can't get people, so the travelers, and so everybody should grow their own population, get local people, local families that want to live in Vermont. It's always the best approach. If you can grow locally, they're going to want to stay, which is key, although there's not a lot of youth to grow, but we're trying to do that. For us with nursing, we are engaged in helping LPNs, helping LNAs, working with the nursing union to accept that we need others besides four-year nurses. I did read the other day an article from a hospital that announced it's going to be one of the first hospitals, small rural hospitals, that's accepting. It's no longer a requirement for a four-year nursing degree. Now, I apologize for any nurses in the room. I don't want to look that way, but when you're that desperate, you've got to figure out how to take care of your patients. You've got to figure out how to get techs. You've got to figure out how to do this. So that hospital is very proud to say we're the first hospital to say we need nurses, but there's no more four-year requirement. So we're trying to creatively grow and also do residency program for nursing, which is interesting. So we can accept new grads that are really, they're minted, but they're pretty green when it comes to their abilities, maybe in the OR or in the emergency department. And so we buddy them up for up to a year so that they become confident and competent, and then they stay. It's important to develop that competency and confidence, but it costs a lot of money. But if you don't creatively figure this out, you're just going to be hooked on travelers, and that's really expensive. So that's just one piece that we're trying to do, and to work with everybody to say we need to figure this out. And a lot of them grow and pursue other degrees, and some of them become nurse practitioners, and you want to encourage that. Some of them become doctors. It's great, but we have to figure out a lot of these things. So that's what we're doing on nursing.
I would just add, as it relates to COVID, right, it has changed the workforce, and we also have our AHEC partners and those programs going down to the high schools and other levels to really create. So this grow your own is really important. And I think that's been, for me, being in healthcare longer than I'd rather admit, is probably the biggest game changer. The other piece is, in probably definitely all of us in this room, right? The pandemic was the first time really going through something that affected us society. And because of that, I think that has played a part in the uptick in behavioral health and maybe has opened up the acceptance of it's okay to talk about, I need a little help, but has created that. So the collaboration that you've been hearing today, that is going to be a key focus and maybe is an output from COVID that really just got everybody together, because for the first time, everybody was dealing for something that's totally new that nobody really had a lot to draw upon.
I would want to add that I think for us, the mental health system, the designated agency system, is a fairly low-funded operation. We're very good at cost containment. But one of the things that we brought through this is the establishment of an educational fund for our staff, because as Joe has alluded to, and Stuart as well, that we can't really depend on being able to pull people in and who haven't been working in the field. We have much more success, and actually recently I've had a couple of people come back who left working for us as BA level folks and have come back with their nursing degree, with other degrees that have allowed them to take in some of the positions that have been harder to place, which are primarily the therapist position. And one of the pieces about that COVID really changed, I think, I don't have this directly from CMS, but the decision to lift the refusal to recognize licensed community mental health providers for Medicare that starts next year is going to be a huge change in the mental health availability for elders. I mean, that was an archaic, ridiculous, and I graduated with MSW, but I am a licensed community mental health counselor. But I think those kinds of changes, and I know you really alluded to the telehealth piece, but we never would be using it at the level that we're using it now. And it's not just about the patients, it's also about the services, because we're in every school in the county, and that's ranging from Walden to Cambridge. And that means that, when we try to have a staff meeting, in the old days, it was getting everybody in one place. Now we can have staff meetings where we can get everybody in because we've really built the telehealth system. And so I'd say in a number of ways, that's really made a difference.
We're not on this panel, but I had a quick, sorry, it's kind of both of your question, the staffing thing. We've had a staffing barrier, but it's actually kind of been opposite what most have been. We're very fortunate to say that we're fully staffed. The only time we've had to use travelers is when we've had somebody out on maternity leave. So again, we know we're fortunate. But I think one of the reasons we're succeeding is our culture, and we're very flexible. Our licensed staff work 4-day work weeks. They only have to work one weekend day. I think it's every 6 to 8 weeks now. And they have holidays that are rotated on a sign-up basis. So that's all, really conducive and appealing to, working families. And, obviously daycare challenges are huge. I think we all can say that no matter what the industry is, daycare is tough. So we are very flexible in that regard too. I mean, we basically run a daycare sometimes. I mean, our HR director has her son in once a week. I mean, we do what we have to do to keep these people. And I think at the end of the day, you have to just say, if they're important enough to keep, which they are, because they could go anywhere and do anything right now. It's the world's their oyster. Then you have to be flexible. You figure it out, So I just wanted to say we offer a lot of other things, but the flexibility, I think, is what sets us aside, so.
I just wanted to refer again to telehealth. It's improved access in terms of visits, but for a medication like Suboxone, buprenorphine, that is a scheduled medication, having the waiver extended to be able to do the initial visit remotely and even having to see someone within 30 days in person has really expanded the horizons for people getting into treatment quickly. And the time from expressing a desire to get into treatment to getting treated initially can be the difference between life and death for many, many people. So that regulation itself has been so life-saving for people and life-changing for their treatment that I just wanted to emphasize that.
I would say that one of the first, go ahead.
So it's funny because during COVID, I became the chief COVID officer at Copley too, and much of my professional life for years was dedicated primarily to helping the hospital and the community navigate through that. But until you just asked, I never really thought. It's like, well, what did you learn from that experience? Other than we never want to do it again, which would be great, but probably unlikely. And of course, our experience, there's lots of the clinical staff from Copley and colleagues across the way there. Our experience with COVID was a little different. There was no really working from home. Our job was to be there all the time. And but two things really stand out. So medicine is definitely a team endeavor anyways, but working together to solve the Copley problem definitely kick that up into high gear, and tremendously grateful for the people's help. Early in COVID, looking at Dr. Blansky across the table here, early in COVID, we were thinking that all the doctors were going to get sick, and we weren't sure how we were going to take care of the patients still in the hospital. You probably heard some places that people that had COVID were coming and taking care of people who had COVID if the doctors could walk and the nurses could walk. We never got to that, thank God. But we did develop a backup list of community physicians, and I remember talking to Melissa about this, and people were happy to volunteer. It's like, yeah, put me on the list. If you go down, I'm like, I'm next into the breach, no problem. And so that was great. And beyond that, just thank God we went through this in Vermont. It was amazing. I don't know if everyone knows this, but Concept 2 came through with hundreds of thousands of masks when no one else could get them. And they just did it. It wasn't like, oh, like, how can we help? And people they might mean that, they might not. They just did it and showed up. That was great. We did a lot of vaccinating through the VFW. You have never seen people so happy to help out than the vets at the VFW. It was just a wonderful experience. So yeah, so those two things. So please never let it happen again. And it's great to have teams of people that you can trust to work with. And living in Vermont is really great.
It was a time of intense collaboration and cooperation, and Dawn, you and your team just did a fantastic job, and Jen and her team getting the vaccination clinics going. It was just an amazing thing where everyone in the community was involved, and that was truly inspiring. What in the outpatient realm, one of the first things that became really apparent to us is what a nightmare fee-for-service is, even though we already knew that anyway. But this idea that you get paid for the time you're in the exam room with the person and all the other work you do is unpaid. And I'm used to doing at least 2 hours of unpaid work every day. But when COVID happened and everybody sort of hunkered down and stopped leaving their homes, I went from a vibrant working medical practice in one day to being a volunteer phone bank the next with no, you don't get paid for any of that. So we were dealing with, many hundreds of phone calls every day and we had no resources. So we had to figure out, who could do work from home? How are they going to do that? Technologically, we never had that model before. And we had to figure out how are we going to get people paid who could be laid off, and we let our teams sort of work out. Some people needed to go home; their kids were now homeschooled, So it was very hard to figure out how to keep doing what we needed to do, how to keep seeing the patients, because people still needed to be seen, and how were we going to be safe, and how what if we all got sick, and how could we cohort our staff so that if this team got sick, the other team would still, and that they didn't all get sick at the same time, So there were a lot of logistical things to figure out, but it really brought to just right to the fore how fee-for-service doesn't work because there's so many other ways that we take care of people. And if telehealth is not paid fairly, that, that handicaps us. If the working with meeting people where they are with phone care and doing other things in the community and having time to be able to collaborate with Dawn and Joe over at the hospital, all of that stuff's super important and not compensated under the way that we're paid right now.
For us at Jenna's Promise, we had to deal with it in a kind of different way. We started in 2019 and we really got our feet under us in January of 2020. So you can imagine how difficult it was to all of a sudden, boom, here's a massive pandemic. And we found that when everyone went home and isolated, that it made our situation a lot worse because with isolation came more use, it came less talking about it, came more overdoses, came more just an immediate need, and our phones were ringing off of the hook for services and care that was just really hard for us to try to figure out the best way through it. We were still new ourselves figuring all of this out, and now we had people who were in crisis at higher rates than they had ever been before, and we were getting the introduction of fentanyl on a whole new level on top of that. So we had families in crisis, we had people in crisis, and it was just all, are maxed out and just trying to survive to the best of our ability to help the next person, to help the next day. And we learned a lot in the first few months, definitely. But that was a learning curve for us, definitely.
Can I share something? So I'm trying to frame your question in a looking forward. How can we also save money with those lessons we've learned? Because we learned a lot, and there was a lot of collaboration that was extremely important, and it was pretty scary now thinking back to it. But when I think looking forward, what are some lessons that might come through? I remember being on a board meeting with the Vermont Academy of Family Physicians just as we went remote, and having Tom Peterson said something really memorable. He said, this is really, in some ways, he's like, this is like family medicine's golden hour. Because Melissa's describing the first 2 weeks where really nobody showed up, and we were doing hours and hours and hours of free care and triaging people and calming them down and like calling them back forever. But then we entered a phase where people were still not really going to the ERs. They were scared to go to the ERs. They were unable to go to the specialists, and they were all coming to us. So and we also had all these influxing people from like Boston who were used to seeing a gynecologist, a dermatologist, an endocrinologist, and a cardiologist. And they'd come in and be like, well, I got my care with all these people. Like, how do I do this now that we can't go to the hospitals and we are afraid to go to the ERs? And we're like, well, we'll just do it. So they were like, you do that? I was like, yes, I do pap smears. Yes, I do INDs. We x-ray people, we do casting. I mean, even just when I think about today, this morning, I did an IND, I did 2 IUDs, I did a lot of stuff. I did like 2 IUDs and an IND, that's what I was getting confused about. Had a patient here for a mat visit and called the nursing home a couple times about some stuff, and called a woman back whose kid had a broken leg last week and needed some help, and got that figured out, and I took care of that too. And so it's like family medicine is so efficient. I mean, it's been shown for a long time that we can provide high quality care at the lowest cost to small communities at a very high evidence-based level, and we triage when we need to. But patients have this habit, especially in cities, of self-referring and over-specializing, super fragmenting care and driving the cost up like you wouldn't believe. And when people stay at that specialty level for simple problems, it jams up the whole system, and then we can't get in people that actually need the high specialty care. So we have this D jelly bean in our EMR that is all the documents that come from everywhere for all of our patients. And if I have 1,500 patients and I get every document from every specialty visit and every ER visit and every urgent care visit, it's a lot of documents. And I sort of am supposed to read them all. And I would say, and I'm not going to try to diminish the care that's being provided by so many other people, but I'd say a lion's share of it we could have provided if we had the capacity. So what I've said for a long time, it's not about competency, it's about capacity. We need the workforce, we need the providers. But in some ways, I think about that as like one of the life lessons of COVID is patients were coming in saying, can you take care of this? Because I don't know where else to go. And we were like, sure. And they were like, we didn't know you did this. We had no idea we could come here for this. And it's still happening, right? So I like to kind of promote that as a one-stop shop. Let's see what we can take care of, and we could really improve the cost of the overall system if that was considered the bedrock.
Can I ask Katie a follow-up question from the gallery? You spoke a couple of times about letting people work at the top of their licensure. It seems very related to what you're talking about now in terms of workforce. If you're
There are very humbling moments where I have to hold my tongue because patients say, well, I'm sure you know what you're doing, but I really want to go to somebody that knows what they're doing, or something along those lines. And I really like to have our staff work at the top of their license. I'd also like to be able to work at the top of my license, and I don't feel like I can with the demands of patients oftentimes these days. Patients want what they want. They want the MRI before it's indicated. They want the endocrinologist when I can do it. They want what they want. And there's some point where I just have to say, it's easier just to give it to them. Write the referral. It's too much time to argue with, and they're not going to believe me. They don't trust me or something. There's some barrier.
So it's not organizational, it's cultural.
Somewhat. It's mixed. It's complex. They get it from their grandmother told them they had to see this, whoever, rheumatologist, and they get it from Google, and they get it from the specialists themselves. I'm sorry to talk so much, but I have a patient who went to the ER and they had a suspicious lung mass, and he went to see me, and I ordered interventional radiology to do a biopsy. Somehow we went to pulmonology, cardiology, hematology, and some other person before he got the interventional radiology lung biopsy. I was like, what just happened? I was getting all these notes from all these people because the referrals were going between the specialists before they come back to me. So it was just like this crazy mouse, give a mouse a cookie book, right? Where you're like, what is going on? Yeah.
I think I'm going to pause there because we're starting to get into actually what will be our next topic, which is cost containment and coordination of care. So I think this is a good jumping off point to make sure we have enough time to hear our experts on that. So we'll take, it says 5 minutes, I kind of like 10. So why don't we come back at 2:45 and we'll switch to the next panel. Thank you. Okay, thank you everyone. We're going to resume. And just so folks know, we'll go with the panelists for about 45 minutes. And then after that, we'll have questions and public comment. So we'll go through and hear from the panelists, and then we'll open up to folks if they have questions. This panel is on cost containment and coordination of care. And one of the issues we're hearing from quite often is that there's challenges in getting patients out of hospitals to long-term care and back to their primary care or wherever they need to go. And some of that is challenges with the staffing and just shortages that we have. And so we want to speak with, we have presenters from home health and hospice, we have a hospital, we have the FQHC, and we have a nursing home to discuss these issues that they're seeing and how they're dealing with the, what I'll call the coordination of care across these entities. So I'll start there and open it up to the panelists.
Hi, I'll start. I've got a couple barriers I kind of wanted to talk about. And one is hospice care that we provide in the nursing homes. And one of the strangest parts of this whole thing is we provide the care. The nursing home, then we have to bill for the room and board, which usually they do for a traditional manner patient. But since it's hospice, we have to do the billing for them, and then we bill Medicare for the service. They can get paid within 2 weeks. It takes us 4 to 6 weeks to get paid because Medicare has to notify Medicaid that they're on service, and it slows the whole process down, which is very difficult for the nursing home to have that loss of cash flow. So we can't pay them till we get paid, then they're sitting waiting for us to get paid. So it is a huge barrier to provide hospice care for patients in the nursing home. Although we we help over there with nurses' aides, with nurses, with volunteers, so it does help with their staffing, but the financial impact for them is incredibly difficult. So it is a Medicaid issue that we've been fighting for years, and all we're told is that's the way it's always been. So we can't seem to get that changed. So that's a barrier that we're fighting all the time to make sure we have enough cash flow flowing over to the manor so they can keep their doors open too. The other thing I wanted to talk about was the cost of health insurance for our employees. It just keeps going up and up and up. We pay half of a family plan. The employee pays the other half. We have an employee she's been with us 15 years. She's just ready to do something different. She's going to move to the private sector. She's going to work for an employer with less than 5 employees. She is now going to be able to go on the exchange, get the same plan. She will get the subsidy, and she'll have $500 more in her pocket. Yeah, so it's very difficult, and as the rates keep going up, it's difficult for us. We can raise what we give our employees, but it's not fair to the employees that don't have health insurance through us. And then I can't give them a raise. So there seems like we are missing this subsidy piece for our staff. Somehow they should be able to qualify, or we should get a better rate or something so we can offer these benefits even to our lowest paid employees. So that's a huge barrier that is only getting worse every year is the rates for all these health insurance. Can I do one more? On the Medicare Advantage plans, they're terrible. There's really seems to be no oversight on them. They're very difficult to work with. They say that we should bill them like Medicare. That is not true. We feel like we're teaching them all the time how to bill. You can't send a clean bill because you don't know what they want. You can't find anything of how they want you to bill. You can't get anybody to talk to you of how to bill. You have to be in the network on some of them, and some of them only want a nationwide contract, which of course we're all separate entities, so we can't get them. And lots of times we don't even know what carriers have come into the state until we're checking eligibility, and then there's a new one listed and we're like, when did that one happen and what's the deal with it? And unfortunately, the old people get calls all the time about their health insurance, and do you want to switch because you can get 5 free delivered meals, or you can get a ride to the doctor's office, or whatever it is, or they'll hear, your dental care is covered, but it doesn't cover home care. But they don't ask that at the time because whatever their problem is at the moment is what they're dealing with. So we have lots of money outstanding. They don't pay their bills for 90, 120, 150 days. So we sit on a lot of Medicare Advantage plans. So it's a big problem, and it's a lot of time our staff has to spend chasing all this money.
Can I just jump in that Medicare Advantage, why don't we as a state just ban that? So you can laugh, but we banned billboards, right? Eleanor Roosevelt, Beautification of America. We're one of the only 2 states to do it. And they said, we don't want that advertising. We don't want to trash our state. We don't think of good ideas anymore. We're so politically correct. None of us have any good ideas, but Medicare Advantage is not helpful. It's a salesman's game. It's ridiculous. They promise stuff. It doesn't work. Our billing office hates it. I could ask the CFO, Jeff. Now he's paying attention. Jeff could stand up and tell you, but it's like, if you really look at the Medicare Advantage programs, they're typically run by for-profits. Well, you got UVM doing it with MVP. Well, whatever. They're in America, they're done by for-profits. You can invest in them, and it's like, you ought to look at it, because I know VPR did an expose on this 6 months ago. I mean, the Medicare Advantage plans don't work for a lot of people. And I don't know why we don't get a little backbone and try something different. Why can't Vermont be a special state? We think we're special. Maybe we ought to try something special. Otherwise, bring back the billboards. Thank you very much.
Can I ask a question? What percentage of your patients are you seeing on Medicare Advantage plans?
I think we're like 11 or 12% now, and it's going up.
Wow.
Every year it goes up. Our Medicare, straight Medicare goes down, Medicare Advantage goes up, and our straight Medicare used to be what really carried us, because our Medicaid money, we lose money on every single visit that we do, so we have to cost shift from Medicare to make our bottom line work, and the Medicare Advantage does not help the situation at all.
Yeah, there's pretty aggressive marketing in Vermont. I have Kevin Mullen's old phone, and I get 3 calls a week asking if I want to join a Medicare Advantage plan. And I keep wondering why they're calling a 44-year-old guy. So I'm aware. I am curious. So 11%, and 2 years ago, what was it? 3%, 5%?
I would have said probably around 5. It's probably doubled for what we were. And if you call one of these plans, I did call one to see what the home care, if they could guide me, because they all have these wonderful guides that can tell you anything you want to know, just watch TV. And I called one to ask about the home care benefits. She had absolutely no idea what I was talking about, which was really scary to me, that old people just don't have a clue what our elders are signing up for.
And you said something about the networks that they have. Is there any concern about steering patients through the networking limitations?
You have to have a contract with some of them, and some of them won't let us in because we're not nationwide.
Or there's somebody in the area that's, within the geographical area that's already got a plan, or a contract, so then they won't let you have one. That's happened to us.
Kathy talked about the barriers. I'm just going to talk about the collaborations. Yeah, sorry. Get everybody all. Some of the collaborations that we use alleviate some of those challenges. Copley's probably our biggest one. I mean, really, I said it earlier, but I meant it. The list is kind of endless. We ask, they just provide for us. I mean, so we can't do anything about some of the barriers. Those are out of our control, but the collaborations are what really make the day-to-day difference. We share a quality informatics officer. We share a chaplain. They let us host events there, like our hospice remembrance ceremony and our staff appreciation awards. We use their room for our skills day and their equipment. Our clinical director attends discharge planning 5 days a week with them, which helps us keep in the loop on, discharges coming out and referrals, which is huge. We help them with their COVID clinic, which it's weird to say, but it was so much fun. I mean, we so looked forward to that. And I'm not a nurse, so I didn't give shots, but I get to work and, just be a part of coming back into the community. You're seeing everybody. So and they did an excellent job getting everyone back to work. I mean, getting us all back to really to living again. We do our emergency preparedness drills with them. Kathy sits on their board of directors, and then we both sit on their foundation committee, which they call the baby board. Another, Jenna's Promise, they had an issue with fentanyl and called Kathy, who then coordinated with Joe and kind of got those things going. We coordinate with the Manor on, we adopted families or patients at Christmas time to do their stockings. As Kathy mentioned, we have patients at their facility. So, we help by bringing in LNAs and other nurses. So that's also nice. And we share our IT directors with them. And then our disaster recovery plan. So like we have their server, they have ours. So all those little things in mental health, I think we were a part of the Zero Suicide and that initiative. So those collaborations are in our little local community really do make a difference. I mean, in the day-to-day. That's right. And the food trucks. Oh, the food trucks. I could probably talk about that for an hour. Those are the highlight.
Okay, so I didn't really put a lot of time and effort into preparing for this, so I apologize. But when it comes to cost containment, there's one person I want to thank, and that's my grandmother, because she taught me that if you pinch your pennies, the dollars take care of themselves. And before Joe was the CEO of the hospital, this was in 2007, I had to apply for a certificate of need to expand the beds at the Manor to nursing home beds. And the Public Oversight Committee, all the three-piece suits sitting like there. Yeah, like you are. And then I'm sitting like there. Yeah, okay. And I had to prepare a forecasted 5-year budget. So I did that, and I presented it to them. And they had a comment about it at the time. I didn't really understand, but they said something about, well, if we could keep Copley, if you can do this, and then Copley, I don't know. Anyway, I don't think the budget was under much control at that time, but I've kept mine under control. So I'm the financial person, I'm the CFO, I'm the CEO, I'm the whatever ED. I don't have the resources or the finances to afford, those sort of positions. I have an accounting director. But cost containment in a nursing home just happens naturally. We have about 64% Medicaid census, so we're running at a very, slim to losing margin on that. Like Kathy said, the Medicare reimbursement is where our need is, our greatest need, and it's our lowest census. We have, I think, 3 Medicare patients out of 55 right now. We have 12% hospice, and so we're not making any money over there because it's the Medicaid rate. And our private rate or census rather, is about if I can remember correctly, about 11%. So we were operating before COVID at 98.6% occupancy. We're now at 75 to 78%. And we have a lot of empty beds, but we have no we have workforce. But just like every other healthcare agency here today, we lost a lot of workforce because of the fear of COVID. And when we mandated vaccination, we lost some more. So we're building back up. We do have agency staff. It's about double the rate of, a hire. But we're not paying any, external costs. We don't pay workers' comp. We don't pay health insurance. We don't pay, their FICA tax. So we're saving there. And they don't have broken cars and sick kids, and they come to work. So when it comes to licensed, nursing nurses, it's actually kind of a budget neutral. But it's the LNAs that we desperately need. They are the backbone of the facility. They do the hardest work, and they get paid, more than ancillary staff, meaning housekeeping, laundry, dining. But they don't get paid as much as they should get paid. So our rate for an LNA is $17 an hour when they're new, and then we add 2% for every year up to 10 years, or higher if they have good experience. But anyway, it's balancing that with staff that are already there who may have worked for us for 10 years. So you can't start somebody new at a higher rate than who's in your house for 10 years. So there's a lot of things to consider when operating and talking about cost containment. We've lost money, and I'll be honest, $400,000 a year every year since 2018. Our fiscal year starts October 1, and we have a gain of $6,000 year to date. So, yay! But I keep a close eye and close handle on finances. And I set expectations with the directors. I've questioned the budget expenses. Our food cost is about $7 per patient day, and he always goes over that $14,000 cost budget every month. And I let him know. But anyway, so I don't know what else to say about it. It's just something that we just have to do. And we have to live within our means. And with that, I will just turn it over to the Director of Nursing to talk about coordination of care.
Lynn, before you, I just want to buddy up to what you said about the LNAs. The other frustrating part, our PCAs, our homemakers, they make even less than an LNA, and they're detriment. We need them for our hospice program, but we can't increase their rates because we're held hostage by rates. So it's so frustrating when you see an ad for a bagel place at $25 an hour starting to slice a bagel, when we have PCAs that are doing such important work. They are underappreciated. And it takes a special person, but it's so frustrating that we can't pay them more because we're held hostage by rates. And it goes for the same for LNAs. It's frustrating. So I just wanted to buddy up to that.
All right, collaboration. First, I want to thank, during COVID, obviously, the nursing home, we were one of the first to be completely shut down, and it was devastating for the residents and the staff, and scary, just like it was for everyone else. But thank you to Copley. We worked closely with them and coming up with the COVID plans and infection control, and same with everyone else at the table, but thank you. And for home health, we collaborated getting PPE supplies, and so that was helpful. And so that was great collaboration, and our weekly calls that we had for a while, and it was scary, but it was good. Yes, it was very helpful. I'm totally jealous of your collaboration with Copley on the food trucks, though, I must say. We want in on that. On the food trucks. So, but anyway, but thank you, seriously, everyone at the table, and same with Lamoille Health Partners, and we just recently met to discuss some issues, and we came up with a plan, and working together is definitely very helpful. So, thank you, everyone. I don't know if you have anything else to add.
Well, I said I wasn't going to talk. I always say that. Well, I'm a little jealous about home health being at discharge planning meetings, and I would like to ask that the manor be at discharge planning meetings. Okay? Okay. I think that was the only thing. Other than that, I just want to also really thank Joe Wooden, because without the healthcare leader, and let's face it, the hospital is the primary healthcare leader in the community, and without Joe Wooden, none of us would be sitting here, I don't think. Joe is the reason why we collaborate. He's the, he knows what he's doing. He's done great work at the hospital. Not that I'm an expert of that, but I am knowledgeable about building an organization and performance, and I really want to thank you.
Do I have to go next? Thanks a lot, Len. That's great. And you can come to those meetings. I usually don't want to go to meetings, so if you said you want to come to a meeting, we're like happy to invite, right? Right, Jen? There we go. Cost-saving ideas. Well, collaboration, it's important. You guys saw the map. We're all together up on the hill, so we have food trucks, so we invite everybody up on the hill to come and use the food trucks. Some organizations have little raffles, and they give away coupons for their staff, $5 each. So if you want to get on any of that, we offer that to everybody, but it just helps and it's fun. Gets out of your shop, clears your head, and it's helpful. So we try to do that once a month and a few things, so that's kind of great. And then the other thing is at the end of the year, sometimes we give gift certificates to shop local. It's like keeping care local. It's very important. If you can keep care local, that's helpful. So we actually give away sort of gift certificates for $50, and it's just a list of local vendors, and you have to do it, and the folks over there do it, we do it. I think, yep, Michael's shop did it, so we try to do those things to keep care local. Few things that we've done that I think are sort of helpful. It's interesting. The state did a recent report, assessment of all the hospitals. We don't have any ICU beds. We're one of the only places that they said, how many ICU beds do you have? We said, we don't have any ICU beds. Other critical access hospitals ought to look at what we did just because it's helpful. Because if you have an ICU bed, your requirement for the nursing staff ratios, particularly have a union or not, are so high that it's really hard for you to say, because the acuity of patients, it's not an on-off switch, it's a dimmer. So when they get to that point where you need a true ICU bed, we'll send them to UVM. But otherwise, you can sort of ramp up some of the care and manage without that problem of saying it's a med-surg bed or it's an ICU. So we got rid of that problem years ago, and it works and it's fine. And there's no huge financial loss on that. Is there, Jeff? He's not paying attention. Just kidding. Just kidding. So that's one thing. We actually now, we just sent our chief nursing officer to work in Springfield for 4 months. We do those things to collaborate, not just locally, but if there's other hospitals that need help, usually hospitals that are independent and small like us. So Lori Profada is going down to Springfield for 4 months to be a CNO, COO. And we're going to try to figure things out and work and sort of help them out. Springfield, you know better than I, has been through a lot. So when somebody needs help, we try to collaborate. And I think that's important. We also send Dr. Cunin, Adam Cunin, who's a cardiologist. He does 0.5 FTE in St. Albans at Northwest Medical Center. So they needed help, asked us. We figured out because we hired another cardiologist. So it's important. Otherwise, we can keep calling travelers in a variety of ways. But I think hospitals should help each other out, even if it stresses you out a little bit. We have a very competent pharmacist. We have some other people that are really competent. And if somebody needs help, we should be promoting that in the state as opposed to picking up the phone, getting somebody from whatever, Alabama, that doesn't understand Vermont and doesn't really help and fit in. And we have helped out the manor with staff and labor through COVID. We're happy to do that. And we also have that collaborative relationship. Their LNAs sometimes become LPNs. And then they become nurses, and then they maybe work at the hospital. So it's so important that we have those relationships with each other because we really do need each other. So the shared staff piece, keeping care local. I don't know if there's others, but there's a long list that I could reference on what we could do to sort of help Vermont, all of us, whether it's tort reform or statewide group purchasing for all of us to make sure, imagine if we all bought. So I would love to be able to offer to every one of the folks in Morrisville that provides healthcare, come join us and we'll do group purchasing, which we currently do through Dartmouth, through NIA. But you've got to sort of force those things, because why should somebody keep having separate contracts with WB Mason or whatever, when in fact, if we group purchase or do group laundry or blah, blah, blah. So that stuff is important. Yep, I'm trying to, oh, you know what I'd love to see now that I got your attention? Centralize, streamline the enrollment process for all new providers that come into the state. So every time you have a provider come into a hospital or healthcare system, well, the hospital, they have to be credentialed to your internal credentialing process. That's fine. But then they go through a second credentialing, which is called enrollment. So it's a little special word. It's an insurance company word, but it's basically credentialing. And it's kind of ridiculous that all of us have to go through separate enrollment into insurance companies, when in fact the state should mandate and say, listen, once you're enrolled in Medicare, you're automatically enrolled in Blue Cross, MVP. There's no gap, and you don't have to waste your time doing that. Did I get that right, Jeff? Yeah. Jen? Yeah. That would save us a lot, like just have automatic commercial and insurance enrollment. There's a lot of those statewide things that we could probably look at, but thanks.
Yeah, so I guess I'll take the cost containment last. I do have a couple thoughts on that. As far as the coordination of care, I'm reading the starting question here, where it says that inpatient wards in emergency departments are overwhelmed with patients who should be moved to skilled nursing facilities or mental health care settings. That's absolutely true, and I guess I would take issue with the overwhelmed word. I would replace it with stress. The director of our ED is here in the audience, along with our head nurse in ED and one of our ED nurses, and I really can't imagine any circumstance that would overwhelm them. But it certainly makes their life very much harder. And as hard as it is on them, particularly when we talk about psych patients in the ED, and the place like Copley and like pretty much every other hospital in Vermont, as bad as it is for us, that's really not where I don't think the focus should be, because when the psych patients are stuck in our ED, we're not doing anything for them. They're being warehoused. I mean, it's a horrible situation. And what's even worse is that pretty frequently they're kids. And I know people are working hard on that, but if you have to see a 12-year-old stuck for days in an ED room, it's a horrible thing. It's pretty soul killing. So if you can fix that, that would be great. The care management team, when they knew I was coming, they asked me to mention a couple things. The Medicaid Advantage plans, definitely one. So check on that. I would add denials. The majority of the denials we get for payment come from them. And they have a couple really interesting techniques. I got one the other day that was like April 5th. They sent the letter, and the period where you can do a peer-to-peer, which is when you talk to another doctor supposedly who knows something about what we do at a hospital, and to like justify like why the patient was hospitalized. So even though they sent a letter on the 5th, if I didn't call by the 8th, the door had closed on that period, which is like, that's impossible. It's like the letter probably didn't even get to the hospital till the 8th. Never mind, it has to go through about 4 hands before it gets to me to do it. So that's just the kind of thing to do. I mean, they're operating in bad faith. It's just that simple. The other thing that seems quite fixable as far as patients getting stuck on the floor is choices for care, which is Medicaid payment going to a place like the Manor. So this is all internal to the state, and during COVID, somehow they figured out how to do this in a week or two, which still sounds awfully long. But last week we had a meeting and someone was 45 days into the process and still they hadn't heard about it. I mean, like, really? I mean, this is pretty low hanging fruit. All right, so that's that. So cost containment, obviously, if any of us had the answer for cost containment, and by any of us, I mean any of us, we wouldn't be here talking about it anymore. So we probably don't. But I think both Owen Foster, Dr. Volansky, and Dr. Marvin, I think both have stated the idea that is probably the only way that we can make any sort of progress toward this. And that starts with an observation made by a guy named William Baumol, B-A-U-M-O-L. He's an American economist in the 60s. And he made this observation that when Beethoven was writing his music, a farmer could produce a certain amount of crops. But today, sitting in a combine, he can produce about 1,000 times more. So the productivity of farmers went up hugely during that time. But the cellist playing the string quartet piece that Beethoven wrote is exactly as productive today as he was when Beethoven wrote the thing. And doctors and nurses basically follow that same rule. I mean, you could replace this with maybe robots and have lots of robots going around, but people taking care of people, it takes a certain amount of time. It doesn't scale unless you get zillions of us, and of course that costs more money. So that effect is kind of hardwired into this whole thing. I mean, is there waste that can be cut out? Yeah, probably some. Are there efficiencies that you can find? Probably some, but both of those ideas they're asymptotic. You will reach a point of diminishing returns where you're spending all your time trying to get rid of like really not helpful little bits of waste and inefficiency. But so that all sounds kind of hopeless. But the idea that y'all gave here, which I think is absolutely true, is that different levels of care, types of care in medicine costs different. And it not only in costs in dollars, but in cost to the patient. And there are two things that are pretty common in general surgery, which I think illustrate this point really well. One is appendicitis. Appendicitis is not one thing. It's really two things. There's ruptured appendicitis and not ruptured appendicitis. If we can get you before your appendix ruptured, we're going to take your appendix out and you're going to be back to your life in a day or two. So you really maybe spend a night in the hospital. You might come back and see me once. It doesn't cost a whole lot. I mean, an operation does cost a lot, but it's really pretty minimal. If you have a ruptured appendicitis, you could be in the hospital for a week or two, and you're not going to be back to your normal life for maybe a month or two. So it's going to cost a ton to take care of you, and it's hard on the patients. So if they can get in and see Dr. Volansky, who goes, yeah, no, you might have appendicitis, and they come and we take care of it while it's early, then it's really to everyone's advantage, and we're definitely saving money. The other really obvious one is breast cancer. If you get a screening mammogram, find breast cancer, you have stage 1 breast cancer, that is completely treatable, and the treatment is really not all that either expensive or time-consuming for the patient. They get back to their life pretty easily. And but if you have advanced breast cancer, and I can speak with some experience in this. My wife recently is only a year out for treatment for stage 3 breast cancer. It's really expensive and it's really hard on patients. So if you can catch these things early, you're going to save a lot of money and it's better care. And the way we sort of deal with trying to get at this problem, because this idea is obviously not so unrelated from ACOs, right? But ACOs really it's more like a payment trick. It's more like, no offense, Jeff, but it's more like sort of accountant games, really. We're just trying to figure out a clever way of paying people, thinking that will incentivize them to act differently. But we really need to approach this from a care provision point of view. And if we can develop a whole system, which requires us talking to each other all the time and constantly passing patients back and forth, sharing information, then if we really don't have to catch people all that much earlier, all that often to really save some serious money and take way better care of people. So that's all I got on that. Thanks.
There is one thing that's specific to the nursing home that I wanted to bring up. I had mentioned it to another Green Mountain Board member some time ago, and she had didn't know about it. But the nursing homes pay a bed tax. It's called a provider bed tax, and the Manor budgets $356,000 a year for that bed tax. Whether we're at 75% or 100%, we're paying the full bed tax. That's a huge burden. If there's any way to take a closer look at that, I know that they get a matching federal fund for the bed tax, but they also had an excess amount of funds. I don't know, is there a way for them to budget differently so that we're not paying that? Because that's a burden, huge burden. And the other thing, and I'll just mention this, is that we're a not-for-profit healthcare facility, and we've been paying our property tax. Now I know you can't do anything about this, but in the town of Morrisville for as long as I think the building's been in existence, and it's going to be $113,000 this next year. So we have submitted a application for tax exemption, but we missed the April 1st date, so we'll be paying that this year. Hopefully they're going to waive our taxes going forward, because again, we're losing $400,000 or more a year. So we have to find some savings somewhere. Okay, that's all I have to say.
All right, thanks. Just words about cost containment. I think everybody can agree that coordinated care is lower cost care, and that's a very important value to us. And we have, dedicated staff that are daily working with our hospital partners on discharges and trying to reach out to patients who've utilized the ER or been admitted to make sure that their meds get reconciled and they get timely follow-up, and all that hopefully helps avoid inappropriate usage of those resources. Make sure those patients know about how they can access us more appropriately if that was an issue. As far as, what can the state do to help with this? I think Katie alluded to before, it would be really great if there was some sort of statewide approach to pushing care into a more appropriate settings. What that exactly looks like, I'm not sure, but at this point, I think specialists need to be consultants. They're very important resources. They need to be used judiciously. A lot of care that could be happening elsewhere should be happening elsewhere. We have our express care track and our Saturday hours, and we are trying to help decrease inappropriate utilization of the emergency room. But we don't really have the resources to compete with the convenience access that they offer. It's for patients who just have other barriers to coming in. I don't have the capacity to offer a lot of off hours. I have a hard time recruiting for that. I don't have the resources for that. I have seen that the two emergency rooms in the nearest hospital to us have been expanded in recent years, and they need to be updated. But as far as you invest your money on where you want the patients to go. And I think it's just really important that we have not invested enough in primary care, and if we really want patients to go to primary care, that's what needs to happen. We need to invest in psychiatric facilities so the 12-year-old is not sitting in the ER for 5 days or longer. And it's really important, because if we had the capacity, I think you've heard today, there's a lot more that we could do to try to help and make that more affordable. We have some regulatory barriers too, and we've been collaborating with Jill and the team at the hospital around prior authorizations for higher order imaging, which is kind of this ridiculous situation I'm in, where if I get someone who comes into my office who's having the worst headache of their life and they need a CT scan today, and I can't just send them for a CT scan, I've now got to get somebody to call the insurance company and negotiate with them about authorization. If I've got someone that I think might have an appendicitis and I want to get a CAT scan, I have I can't just do that. Have we sent patients to the ER because we're exasperated that we can't get the authorization and we're worried the patient will not do well? Because after the prior authorization, it's going to take several days for them to get their imaging. If I don't feel comfortable with that, yes, I have resorted to sending people to the ER after I've already evaluated them just because I can't get the prior authorization and they don't need it. So if you could remove that barrier, that would be fantastic. If we can get rid of Medicare Advantage plans, we can get rid of prior authorization, that would be great. Just warm up the magic wand. Thank you. We would love to participate in some sort of alternative payment model, some sort of payment reform. As I've said before, the fee-for-service arrangement is a disaster for us. A lot of the healthcare reform that has happened already has come with a lot of burdens, reporting burdens, data reporting burdens. For years, family doctors, many doctors, but I'll only speak for my specialty in particular personally, is that we have this care coordination baked in. We have the idea of taking care of the whole patient ingrained in us. It's an integral part of our training. We have been providing lower cost care for years, and we've just been waiting for someone to come along and make us whole. We're bailing our boat as fast as we can, and when healthcare reform comes along, they put more people in our boat who aren't bailing, and it doesn't really help us get back up on top of the water. So we really need help, and we need, we have a smaller practice in the community that couldn't be here today, in the Tamarack group. And I talked to them a little bit about what they would want to say if they were here, and we, Caroline has left unfortunately, but I think we don't want to leave smaller practices behind, and that is a really hard thing that, when healthcare reform insists that you have an expensive computer or system, or that you have people who can feed you data, it doesn't help, and those people are providing important service too. For example, we just lost our Planned Parenthood in this community, and a lot of us are providing long-acting reversible contraception, but nobody in this community is providing termination services anymore except for Tamarack. So I really want to give props to them for doing that. There's lots of communities in Vermont where a small independent practice may be the only primary care they have, and we don't need fewer primary care. Quite the opposite. So I don't, any sort of reform should be focused on outcomes rather than the process, and not leave those folks behind.
I had a quick question on that. If there were a way to ensure specialists were performing at the top of their licenses and the patients were coming back, do you have the capacity to take those patients back now, or would you need investment and support to grow your operation so you can handle that if it came back?
Excellent question. I hope so. It's interesting. I didn't really say anything about preventative care. We really put a high value on that. We really use every visit as an opportunity to make sure people have had all those preventative, even though that may not be what's on the patient's agenda that day. We know that if every single patient of ours came in appropriately for a once-a-year preventative visit with us, we couldn't do it, or we couldn't do anything else. We know we don't have the capacity for that. But I do think we have more capacity to take those people back. It creates a lot of work for us anyway. When people want to use our discount pharmacy, but they want meds that were prescribed by the specialist, and then we have to figure out a way to get them seen or get some referral on paper. So we, and we have to spend, I get it, the D jelly bean that Katie alluded to, it's about 100 a week for me. And every note I get from UVM is 12 pages long, even though if it was only a 15-minute telehealth visit where nothing changed, it's an incredible amount of time that gets spent unpaid. And I would much rather, see those people.
Thank you.
If I could just speak to one piece about the psychiatric inpatient part, I think, as recognized here, that's a jammed up place. It really still hasn't been able to make sense to me. I was commissioner of mental health for 4 years. I am pretty familiar with this stuff. I don't completely understand what the heck happened between 2006, 2007, and now, that we were in a system that used to be 2 to 4 hours for somebody to be in an ED to an inpatient unit. we supposedly have more beds, but now it can take 2 to 4 days easily if we're lucky. So, partly I think the issue is there are more people seeking. Partly the issue is similar to what Melissa was speaking to about the ED. There are people who have identified the ED as a place to go, and once you get there, that changes the whole dynamic of it. So we're trying to do more mobile outreach to be able to get to people before they show up at the ED. But this is also this uncoordinated piece because it doesn't involve you all directly in terms of what goes on the community side of the health equation. And I think that somewhat the experience that we're talking about here is what happens if Stuart throws away some of the rule books and Joe throws away some of the rule books and we breach what some agencies haven't breached and really embrace the recovery community and do some other pieces, and we all really work together openly, that there's a different outcome. But there is still this large system that operates in ways that make it very difficult to do that easily.
So I'm going to suggest a great way to save you some money. Good. So let me ask Joe and Mike, how many people come into for your help, need your help in the ER or for addiction, that you get overloaded your ER where they really shouldn't be? It's constant. Constant. It's heartbreaking. It is heartbreaking. Yes. And I can't tell how many times I've sat in that ER and called for help because that person wants help. And I call one of the treatment centers and you can't get in. And right then, if you could just get that person out of your ER and into treatment, what a huge difference. They go back out, they use. They get back in the ER the next day. It's just yo-yo. It's amazing to me that we don't have treatment centers, only 2 in the state. Addiction has gone doubled, tripled. And pretty soon you're gonna see it in the home health because these people their health is under, out of control. And that's gonna be a whole new need coming up. We have 2 treatment centers. We lost Serenity, Brattleboro, Maple Leaf, now Act One. The need is out crazy. I can't tell you how many times my phone rings a day, and I try to get them in treatment. Right now, I called twice on last Friday to get someone in treatment. We can get you in on June 16th, hopefully. Do you know what that chances of that person living? Or the wounds that are coming from some of these drugs that are just it's a different world out there for drugs right now. And we're losing people to suicide because they're like, I don't want to live anymore. I remember Jenna saying when they Narcaned her, just let me die. And the thought is I can call New Hampshire in the morning and get someone in by 1 o'clock. That's sad. And, or why New York can call Valley Vista and get their patients in, and Vermont can't. And why they get 28 days of treatment and we get 14 in this state. And so I just want you to look at that because I know if we could fix that problem, we could fix a lot of these costs over here, and eventually they're going to be here. So just my thoughts.
Thank you. I want to be mindful of the time. And Jess or Robin, do you guys have any questions for the panelists? So we'll do that. We'll turn to public comment. Any questions?
Hey, I'm Pam Stanion. I'm on the Copley board, and I've got a two-part question and a little bit of problem solving, perhaps, too. So I come from innovation, big consumer packaging goods innovation, and so I always like to think creatively on a global scale, and then step back and think locally, what can we do? So we're talking about healthcare access, affordability, and quality, right? Okay, so the first part of the question is, how can we hold ourselves accountable as the Green Mountain Care Board against these three metrics? What are the metrics that we're looking at, and how frequently are we looking at the metrics under access, affordability, and quality as the Green Mountain Care Board? And I do appreciate the fact that you're here as a listening tour, it seems like, and a little bit of creative problem solving. So thank you so much for that, too. Really appreciate it. And I see accountability in all your documents, so that's fantastic. Number two, under innovation, have we thought about looking at other states or other countries where they do great healthcare outcomes? Have we thought about perhaps looking at, I don't know, let's talk about Minnesota. Minnesota has about 73 people per square mile. Vermont has about 70 people per square mile. We have less than 1 million people in Vermont, and there's about 5 million people in Minnesota. I just did some quick lookups on my phone here, apologies for that. But I think Minnesota might be one of the most healthy states in the nation, is that correct? And perhaps they're doing some things that we could learn from, and perhaps there's some things that we're doing that they could learn from. We are number 3 after all. Let's give ourselves a pat on the back for that, right? So just some creative ideas about benchmarking with other countries, other states, looking at some best practices around addiction or transferring patients, or how to act more locally. So just putting that out there as a thought. And thank you.
Thank you very much, ma'am. Are there any other feedback?
Yeah, I'm Greg Tatro from Jenna's Promise, and like Don was saying, there's always people go to rehab for 14 days, they go right back to the same place they came from. So 3 months later, guess where they are? They go see Joe first because they've overdosed, back into treatment again, which I don't know how much it costs a day there. I know how much it costs a day at our place, but I think this model needs to change, because when they go back to the same place they came from, they have very little chance of success. With our program, they come and they stay with us, and we teach them how to work, and we teach them how to take care of themselves, and we teach them that life's a pretty darn good deal, and this just revolving door. I mean, we talk about trying to get people into rehab. Well, it keeps rotating, and we've got to do something different to change that, because it's not working. I mean, we lost, 240 or 50 people last year. And, everybody in this room is working their butts off to save these people, and we keep losing. We've got to change. It's not working. And I think our program is what should be spread throughout the state. They need to be housed. They can't go back to the same place broke, dirty clothes, living in a crap hole, and expecting to succeed. It's never going to happen. None of us in this room could do that and live. We've got to do something. And that's, it's a huge cost. You guys see it. And most of these folks, they don't have any money. They don't even have insurance. So these guys are working their butts off to save them, probably not even get paid most of the time. We really need to come together and work on a solution, a new solution. Throw the other stuff out in the garbage. It's not working. That's what I've got to say. Thank you.
Thank you. And I think that's really accurate too. I mean, with a lot of overdoses, what you see is an effort to get clean. People are clean and then they're not clean. And when they're not clean, they go back to where they were and their body can't take the dosage that they get. And that's when you have an overdose. The other issue is with fentanyl being added, you don't know who's mixing it and how lethal it is. I mean, it's a grain of sand can kill you. So if they mix up the dosage of the fentanyl that they're putting in the product, you're going to have real serious risks of death. And that's what we're seeing over and over in Vermont is people going back shortly after getting clean. And that's when you really have a lot of problems. So I agree. I think we need much longer treatment. When I was at the U.S. Attorney's Office, and we worked with Jenna's Promise, my old boss, Christina Nolan, was a huge supporter and a real advocate for you guys. And it was great. But we had it too. When we were trying to put people in drug court, we would have people that had to be incarcerated for a period of time because we couldn't get them into treatment. And we were trying to avoid the prison system because there are good candidates for folks who could get clean and live a productive life, but they then had to go to jail for a month before they could get out to go get clean. And that wasn't productive either. So I think the lack of treatment options in Vermont is surely an issue that needs to be addressed, I think boldly. Thank you.
And I tell you the thing too is people commonly have no hope.
And like Ron said, they just assume they don't have hope. And until we can change that mindset, they're going to go back, right? They have to have hope. They have to have training. They need the support. And I think it's so important. I'm just sick of people dying all the time. Sick of it.
Well said. Any other questions or comments?
Yep, yeah. This is also really humbling. I look at Morrisville and Copley Hospital and listen to the comments of today, and I just sit here and say, wow, could things be better? Could there be some more community connection, and how do we make these things work a little bit better? Sure. I don't know the gentleman sitting in front of me, but your passion about saving lives is incredible. And I think I applaud the board for having this meeting in person. I think we got to do more in-person meetings. I think if you go to and replicate this meeting in communities around the state of Vermont, you'll hear and learn similar things and maybe even new things. I always, I heard and learned and bring back to my group a few things from this meeting, and I think we should do more of this in-person space. We get to know each other. We get to sort of wrestle through some difficult and challenging things, and maybe we'll come up with a little bit more wisdom. So thanks for the meeting today. Appreciate it.
Thank you for the comment. Sorry, the gentleman behind us.
So I just wanted to kind of add some numbers to what Greg and Don were saying and try to provide somewhat of a roadmap. And if you look at it, like we always talk from a scarcity mindset if we don't have enough money. The reality is we're going to spend the money now or we're going to spend more money later. That's why prevention exists. But I want to go back to what you were saying, Chair Foster, earlier about incarceration. That is, to me, the ultimate penalty to our society and to the person, the ultimate investment in punishing them for the things that they've done to survive. Over 75% of all people in incarceration, women are survivors of sexual and domestic violence, which is why we partnered with the Department of Justice to target that population. Thanks to Christina Nolan and yourself and other partners, we can, target the people who don't have the resources, who are the hardest hit by these examples. But the problem is that it costs about $65,000 to $85,000 a year to have to incarcerate somebody. We aren't providing the resources in jail to help them when they come out of jail. We're not like peers and others aren't allowed in the prisons to provide support groups and recovery coaching. We aren't, we're not making it a rehabilitative environment. So what are we getting for our money? We're putting them in an 8x8 concrete cell, which isn't good for anybody. If somebody, the average number of times a person goes through treatment is 8 times, the average cost per stint in treatment is $30,000. That's $240,000. One instance of endocarditis caused by IV drug use for not having a safe needle, which costs $2, by the way, is about $125,000. A course of HIV treatment or Hep C treatment is similarly very expensive. We are spending the money. We're just spending it downstream instead of upstream. So when I listen to everybody, I think of what this group, we created in the dawn of the COVID epidemic. We created the Lamoille Area Health and Human Services Response Command Center. It was based on a FEMA model. It was a very effective model that brought together our partners to completely reorient our society to deal with this pressing threat. And what I would say is we are in the midst of a public health emergency. Substance use is a public health emergency. Mental health is a public health emergency. It's time for us to put equal value into reorienting our society and shifting where we put money in to deal with things upstream and to take these crises seriously. And I'll end with one final note, and I would say this, and I try to say this in every group of powerful people who have something to do. We are facing an incredibly deadly cocktail of drugs, fentanyl, gabapentin, which is increasingly being mixed, and xylosine and these other things. The next wave, which our system is completely unequipped at this time to deal with, is stimulants. And methamphetamines and cocaine, crack cocaine, they are here. They are coming in a big, big way. We do not have medication-assisted treatment for them in the same way that we do for opioids. We do not have some of the other treatment modalities. We better gear up because they come with very serious mental health conditions. And so I would hope that leaving here, we start to get ready. The way that we built the hub and spoke system to respond to the opioid epidemic, now's the time to start building for what's coming. It'll always be intermixed, but these things are coming on very, very rapidly, these changes in the drug market, and these stimulants, which are very, we're pumping our kids full of Adderall and Ritalin and other stimulants. And by and large, people tend to stay in the same classes of drugs. People will move from stimulants to stimulants and be more prone to stimulant use disorders. So we will spend the money one way or the other. Let's orient our society and see this for the problem it is. Let's work together. Let's pull our partners together. I think we've done a remarkable job here in Lamoille County, which is why we largely held steady in terms of some of the really negative figures that we've seen across the state. But I would just hope that one of the things that we take away from this is not a scarcity mindset, but the fact that we're already spending it. It's time to just think about it differently. And I just want to reiterate what Don was saying, that we do not have enough treatment. And to Don Dupuy's point earlier is we have these sort of issues of how long do we care for somebody or how many episodes versus how many people. And in the treatment centers, when you have Valley Vista with 90 beds and Serenity House with 30, there's a fixed quantity of beds. So the longer the stays, the shorter, the smaller the number of people. The longer the stay, the shorter the stays, the more people. Again, as Don was saying, we are prioritizing other states' people, and therefore we're having to force New Hampshire and other states to prioritize our people for the reimbursement rates. But we can't close down the care providers that want to come help us out, and we've really got to come together.
Great, thank you very much. And it's true, meth is coming to Vermont. It's here and it's exploding in our communities. You're exactly right. It's here and it's available. And I think your other comment was really well said too. A lot of this is an allocation challenge, right? Where are we putting money? Is it the right place to be putting the money? And what are we getting out of it? So To the extent the care board is involved in money, and we are, large amounts of it, we need to be very thoughtful and mindful of how our decisions are impacting the entirety of the healthcare system. And we are. We get a lot of input, and we're having a really robust discussion about how to do that. But I think your point's right. We're already spending the money. And your point on the prison system, I think, is well taken, too. So thank you for standing up and speaking. Any other public comment at this time? Joe, please. Yeah.
Can I be public?
Please, sure.
Can I be Joe Public? Just two things. One, we really need to save on the expensive care issues that get repeated or shouldn't be in the right environment. We talked about that. You know what I mean? When you're doing something up here and it should be done by a primary care or something else. So if we can do that, that's really helpful and redirect the money. One of my inappropriate suggestions, but I want to be on record now, is this is ongoing. It's been going on for a long time. Suggestion being stop the payments for repeated diagnostic testing when a patient's transferred to another facility. Okay, so when patients get transferred to UVM or Dartmouth, sorry, I'm calling them out because they're not in the room. But when this happens all across America, so this is all across the country. And we, again, should be the first state to say, you know something, we're going to sort of address this. Because if you get transferred to a tertiary care center, typically from a smaller hospital, but even Rutland or Southwest or whatever, they'll repeat the CT scan. They'll repeat the lab work. They repeat, right? Any nurses in the room, anybody who's actually transferred, right? Can you raise your hand, right? They repeat these things. Right. And if you go down to Mass General, and if Dartmouth sends to Mass General, they're going to repeat it. We all know this. We have friends and neighbors. It happens, and there's always an excuse. Well, that CT scanner is not good enough, or we just want to make sure the lab work is really, and so we waste a lot of money. And we should say, we can't afford that. And unless there's a real quality problem with that CT scanner, that's fine. Write it up, own the criticism, and then let's get that fixed. But we do this in America. We've done it every state. And so we're just, we could save a lot of money. I know some folks might not like that, but you ought to look at that because we don't avoid we avoid the difficult issues, that we always trying to, Second thing I want to say is you have to break the paradigms on all of what we're doing. If we had less ER visits because folks are in primary care or they're taken care of at Jenna's Promise, we're happy not to take care of people that shouldn't be in our ER, right, Liz? We want to take care of the people that are really sick and need us, but we don't want our staff stressed. We got to keep hiring more when in fact they could be better addressed elsewhere. We're still going to have staff, but we're not going to, we don't desire to take care of people that should be addressed elsewhere. I want to put a plug in. I don't need to, but sometimes if you have a paradigm and things really shift, whether it's COVID, or you have an event, you get new people, new ideas, and they think about stuff, and they don't even care about the past. They're just going to create their own method of addressing it. And I will tell you, Dawn and Greg at Jenna's Promise, having lost their daughter, they didn't go study 10 other examples of how to address this problem. They have creatively developed a program, and I suggest anybody ought to go for a tour of Jenna's Promise and to see what they do, because they put people to work. They roast coffee. They have a store. They buy Amazon products out of a tractor trailer. They do so much. They have a coffee shop. They put people to work. They take care of people. They do stuff that if we all professionally addressed it as a business model, we wouldn't come up with that idea. We'd do it more expensive and less effective. Thank you very much. These people have thought because of passion and drive. So we ought to look at that. People ought to go take a visit because it's very unique. So what's that? It's extremely successful. So I just want to put a plug in for that and really saving money on the repeated, very expensive diagnostic and lab work that's done. Thank you.
Well, I just wanted to thank everyone for having us and having such a robust conversation and hosting us and showing us your facilities and teaching us about what you're doing. And really Susan, Rebecca, and Kristen and Julia for making us all come together and letting us do that. So thank you, everyone, and have a good day, and we are adjourned.